Hey guys, welcome back. This is Module 4. We're going to jump into rhythm recognition, starting off with sinus and nodal rhythms. Before we get started, though, I really want to talk about what does sinus actually mean. Okay, it means it starts at the SA node. The P wave is present, it's upright in leads 1 and 2, the P to QRS ratio is 1 to 1, and in all intensive purposes here, your rhythm strip, it's normal sinus rhythm. Okay, sinus nodal dysfunction, however, this is when you have an inability of the SA node to produce an adequate heart rate that meets the physiologic needs of the individual. This can result in sinus bradycardia, sinus pauses or arrest, sinoatrial exit block, chronotropic incompetence. That's when you have an increase in demand, like you're exercising, but you don't have that matching heart rate, or tachybrady syndrome. Sinus tachycardia here and bradycardia here. We're going to note that we have a P wave in all of these. The P wave is kind of buried in this top strip, but it is present. So our QRS ratio to P wave is 1 to 1, right? And sinus bradycardia, same thing. We see those P waves are present. And then we take note of our interval, and we can see that it's very close together. It's less than 3 large boxes. Our rate is clearly greater than 100. We're over here, we're clearly extended out. If we were to count 1, 2, 3, 4, 5, and some, our rate is going to be less than 60 beats per minute. And then we have sinus arrhythmia. This is when you have normal sinus conduction, but you have an irregular rhythm. You've got changing R to R intervals. Common in young, healthy people and athletes, frequently related to breathing and pressure on the vagus nerve, and it may occur as a result of medication effects or different diseases. Then we have sick sinus syndrome. Say that 10 times fast. Sick sinus syndrome, right? SA node is failing to generate or transmit electrical impulses properly, which leads to an abnormal heart rates and rhythms. Symptoms can arise when we are not maintaining that physiological demand. And this is most often seen in older adults, typically due to age-related degeneration of the SA node, but it can also be caused by medications, metabolic disturbances, or genetic mutations. And this results in that bradycardia we talked about, tachycardia, which we talked about, or tachybradycardia, which is exactly like it sounds, thank goodness. It is the alternating periods of very fast and very slow heart rate, alternating tachy and bradycardia. So we can see here, we've got our essence of tachycardia here, and then a clear bradycardia on the other side. And that brings us to AV nodal dysfunction. AV nodal dysfunction is when we have impaired conduction of electrical impulses through the AV node. The AV node normally delays and filters atrial impulses before transitioning them through the ventricles, which ensures our coordinated contraction. So when we think about the PR interval, I really want you to think about the AV node delay. Okay, this is super, super important. The reason we care about the PR interval at all is because it is timing out our AV node delay. How well are we able to create this coordinated contraction? This can result, if you've got a dysfunction, in various degrees of heart block, which we'll talk about shortly. Now, what does junctional mean? Junctional means it starts at the AV node. When the SA node is failing or it's suppressed, the AV node junction can assume pacemaker function, which results in a junctional rhythm. You've got a regular QRS complex, so it's going to be narrow, and an absent, inverted, or retrograde P waves. And you'll see many directions. I think very commonly it's absent, or it'll be kind of morphed in with the QRS complex. So junctional rhythm, often we have no P wave. The rate is going to be 40 to 60 beats per minute. Accelerated, it can be 60 to 100, or if we have tachycardia, it's greater than 100. And we're going to see here that we don't really have a clear P wave right before our QRS complex on any of these. It's either going to be flat or we've got kind of an inversion thing going on here. Our rate is very slow, very bradycardic, 40 to 60 beats per minute. This is a junctional rhythm. And in the setting of sinus node dysfunction, high grade AV block or profound bradycardia, we can see our escape beats, which is this guy right here. And this is a protective mechanism, really. Remember, if you have this pause, and if it's greater than 6 seconds, it's a medical emergency. So our heart doesn't want generally to have metabolic emergencies, right? And so we've got these backup mechanisms. So if your SA node fails and it's not working, it's not producing these signals that it needs to, well, your AV node can kick in and produce this junctional escape beat, which can sometimes help get things up and running again. Now, sinus pauses versus sinus arrest. Sinus pause, the duration of the pause is going to be in direct multiple of the R to R interval of the underlying rhythm. So if we were to take our distance from this R to this R, and then we were going to say, okay, that's the same distance, and we could multiply it 3 times, 2 and 3, and then we have a return of our rhythm here, and we resume the same R to R interval. That's going to be a sinus pause. So the same distance multiplies, then we have our beat that comes back, and we resume basically the same pattern. Sinus pause. Sinus arrest, this is just the absence of electrical activity. It's initiated by the sinus node. No electric activity means no depolarization, no contraction, drop in blood pressure, and if you've got an arrest of 6 seconds or longer, it's considered a medical emergency. So think about it like sinus pause, you're just taking a little break. You're pausing on the rhythm, but you're going to come back to it. You're going to come back. Or a sinus arrest, you are stopping. You don't really have an intention of getting started again, and you may or may not, depending on the scenario. All right, rhythm recognition, sinus and nodal. Let's talk AV blocks. All right, 2 different ways to kind of look at this. I learned how to kind of differentiate the AV blocks based on the heart block poem, so I will definitely go over that with you, but I also have this other graphic that I kind of want to go through first. And so you can differentiate heart blocks into these 2 categories. If you're one of those people that really just needs to like, okay, here's the information, how can I like only have to remember 1 or 2 things about everything by splitting it into these categories, right? So we can think of heart blocks as either a constant PR interval or a variable PR interval. Remember, heart blocks are issues with our AV node. If we have AV node dysfunction, we're going to get heart blocks. Okay, so AV node dysfunction, we're thinking PR interval, we're thinking AV nodal delay issue, right? So that's why we're looking at our PR interval. So if it's constant, you're going to be in one group. If it's variable, you're in this other group. Constant PR interval, we're thinking our 1st degree heart block and our 2nd degree heart block type 2. And for a variable PR interval, we're thinking 2nd degree heart block type 1 and our 3rd degree heart block. But that said, let's go through the poem. Okay, this is the heart block poem. I did not create it, but it is, widely used, and I highly, highly recommend, as silly as it is, saying it over and over again until you get it, okay? So we'll start off here. If the R is far from P, then you have 1st degree. So this just says what it says, right? If our PR interval is long, but it's constant, then we have 1st degree. Next line, longer, longer, longer drop, then you have a wanky bach. And I think it helps if you say it in the voice too, okay? But this is exactly what it says. Our PR interval is going to get longer and longer and longer, and then we're going to have a P that does not have a QRS complex. Our signal is blocked. It does not get through. We do not have activation of the ventricles. Next one, if some P's don't get through, then you have Mo beats 2. Okay? Here, we're in our type 2, so this is our 2nd degree heart block type 2 here. So we're in our constant PR interval range. We're going to have P waves that don't have QRS complexes. So our P to QRS ratio is not 1-to-1. And then if P's and Q's don't agree, then you have 3rd degree. And this is one of our variable PR intervals here. So we're going to have P wave to P wave that's relatively constant, and we're going to have R to R that's pretty constant, but they don't match up in a line. And I'll go over that in more detail. So to kind of take it from the top here, right? If the R is far from P, then you have 1st degree. Longer, longer, longer drop, then you have a wanky bach. If some P's don't get through, then you have Mo beats 2. And if P's and Q's don't agree, then you have a 3rd degree. Like, say it over and over and over again. As silly as it is, it will help you, I promise. All right, 1st degree. Whole thing here is our prolonged PR interval. This is typical sinus rhythm. The one feature is that the PR interval is going to be constant, and it's going to be greater than 0.20 seconds. This is the most common heart block. People are born with it every day. All right, so if we look at our PR and we were to compare it across the line, we're going to see that it is long, but it is constant as we go down. 2nd degree type 1, we have wanky bach. Now this unique feature is the presence of a prolonging PR interval from one cardiac complex to the next until it reaches a point where the QRS complex is blocked, it's missing, it's gone, and then the pattern starts all over again. So another key that I think is really important here is that it's patterned. So we have longer, longer, longer drop, longer, longer, longer drop, longer, longer, longer drop. It's going to happen over and over and over again. So if the third complex is dropped, it's always going to be the third complex. The P to P intervals are going to be regular. The R to R intervals are irregular. And there are more P waves than QRS complexes. So again, if we were to highlight and kind of map out here, so this is our first, you see how short that is. Then we get a little bit longer and a little bit longer, and now we have a P wave, but we don't have any sort of QRS complex. And then we start over. We have short, a little bit longer, P wave, no QRS complex. Longer, longer, longer drop, then you have a Wenckebach. This is second degree type 1. Second degree type 2 is Mobitz 2, and sometimes Wenckebach is also called Mobitz 1. It's like the valves of a heart. Everything has 3 names, and unfortunately, you gotta know them all. But here we are. C'est la vie. All right, second degree type 2, Mobitz 2. The hallmark of this is that you're gonna have a constant PR interval with missing QRS complexes. So your P to QRS ratio is not 1-to-1. So it can be present in a couple different ways. You could have QRS complexes occurring in a specific pattern in ratio with the P waves, so 2-to-1 or 3-to-1 block, or QRS complexes occur in a more unstable, unpredictable manner. So if some P's don't get through, then you have a Mobitz 2. So if we look here, we've got P wave, no QRS, P wave, no QRS, P wave, QRS, P wave, no, P wave, no, P wave. But look how everything's regular. The distance between our R to R is regular. The distance between our P to P is regular. We just sometimes don't have QRS complexes. Okay? And then over here, we've got P QRS, nothing, nothing. But see how this is not patterned. Our P waves are still pretty regular, but we clearly are not regular in our QRS complex intervals. All right, and then we have third degree, which is AV dissociation completely. This is a complete heart block. Essentially, the atria and the ventricles are electrically separated or dissociated from one another. They are not talking, they are not communicating. The top half of your heart is doing its thing, and the bottom of your heart is doing its thing, and they're not talking to each other. They're in a fight, right? So you have regularly occurring P waves and QRS complexes, but at 2 distinctly different rates. Presents with regular P to P and R to R intervals and a variable P to R interval. Now, I want to note here, this is very, very important. This is the only heart block where the P waves can be buried. This fact here, this is going to help you distinguish it from Mobitz 2. Where you might have, the regular P's and the regular QRS's, they're just, not always talking, they're not always going through. Okay, but in Mobitz 2, you will never see a P wave that is buried in a QRS. Okay, so let's map out our P waves here. We've got a P wave here. Here's a P wave. There's a P wave, P wave, P wave, P wave, P wave, P wave. There we go. See how the interval from P to P is normal, is regular. Okay, and then our interval from QRS to QRS, also regular, but they are clearly not talking to each other, and we have buried P waves. Okay, if P's and Q's don't agree, then you have third degree. Alrighty, that's all I got for you for this one. We're going to keep going with the modules. If you have any topics that you want to go over that we don't have, I'm still actively producing these, but I'm happy to cover content that maybe isn't covered here. Just let me know in the comments. Happy to produce more for you guys. Best of luck studying for EKGs. You got this.